Good afternoon, everyone. It's my pleasure to introduce to you Michael Ruppel. Michael Ruppel is the Executive Director of the AIDS Institute, a national HIV/AIDS organization with a mission to promote action for social change through public policy research, advocacy, and education. The AIDS Institute's program and administrative offices are located in Tampa, Florida at the University of South Florida College of Medicine, and their national policy office is located in Washington, D.C. For the past 15 years, Mr. Ruppel has functioned in senior management for the nonprofit sector, developing, managing, and providing HIV and AIDS support services in various capacities, including case management, supported housing services, rental assistance, food pantry, financial management, and job placement. Mr. Ruppel has an extensive background in financial and business management and program and project development. In his work with the HIV and AIDS service organizations, he has developed and supervised advocacy and outreach programs, research projects, prevention services, food service programs, comprehensive financial assistance services, direct housing and housing assistance programs, volunteer programs, special events, and fundraising services. It's a great pleasure to have Michael today give us an update on the changing landscape in healthcare. Mr. Ruppel, I turn it over to you.
Thank you, Dr. Beal, and I want to thank the ACA and those of you that are participating today. I really appreciate it. So if you were able to participate last month, you may have heard some themes that you're going to see today, but if you didn't participate, hopefully I give you a full enough picture of what's happening that you will walk away with the information that you need. So participating last month certainly wasn't a requirement, but for those of you who did, you'll see some common themes, because one of the things that we have to do as an organization is constantly update and manage issues on an ongoing basis, and that's what we're going to talk about today. So we've basically broken up the presentation into two different areas. So the federal and the national outlook, focusing on where HIV and AIDS interest is at the federal level, and some policy changes that are going to be coming and possibly could be coming for prevention, care, and treatment, which would obviously impact, I believe, just about everybody on the call today. And then the future changes on the policy horizon, which is always important because we have to be prepared for those. And certainly you, as working in organizations, want to be prepared as well. And then we'll do a quick state outlook on the recent legislative session and some changes to the healthcare systems in Florida and what those impacts might look like for us. So we'll start off with generally the interest of HIV and AIDS in our country right now and with our federal government. And generally speaking, and a lot of you know this, that it's less of a sense of emergency around HIV as it was in the 80s or 90s, primarily due to increased treatment options, prevention messaging, some reduction in stigma, although there's still lots of stigma in certain areas and a lot of work we have to do. But there's a lot of things have evolved over a long period of time, and that has changed not only the reality of the disease, but also the perceptions of the disease. So a lot of people have a lot of misconceptions about whether HIV is cured, whether it is still treatable, and that's a constant battle for us in the advocacy community, because we're constantly re-educating people or educating them for the first time about these issues. And certainly competing health demands. When we're on the Hill in Washington, D.C., and we're doing education visits and we're trying to get our information across, we have other diseases advocating for their patients as well. So there's competing issues. Global HIV and AIDS, that is not only an issue-based, not that we're competing with it domestically, but it does compete with us financially. And then there's some discussion about, should we be putting money toward global programs versus And then, as I said, other chronic diseases and illnesses that have changed the landscape slightly and the discussion. And the biggest misconception about this being historically a gay white man's disease, although that's a fact, there is still a lot of misinformation about that, who is impacted by HIV currently, and what does that look like, and what is the impact on their community, their program, or their issues. And certainly with the CDC's refocus on high-impact prevention in certainly urban areas and special populations, such as minority communities and injection drug users, that has changed the interest and the perception of HIV and AIDS. Congressional support from urban areas. So, a lot of the big funded areas and highly concentrated HIV epidemic in cities, such as LA, San Francisco, Chicago, those are all important because those cities have helped collectively raise the voice of this national epidemic. And with leaders such as Nancy Pelosi that have been our champions for us in the advocacy community, oftentimes don't get the recognition because they do so many things behind the scenes. And having the Congressional Black Caucus involved in HIV and AIDS issues. So the interest is there. We just need to keep it motivated, keep those folks educated on what's happening, because they have a lot of competing priorities on their plate, and we need to make sure that they're always looking at HIV as one of their top-line priorities. And of course, the increased interest in the South due to the high number of cases, a lot of reports that have come out, the Southern AIDS Coalition that was founded in the early 2000s, and has really been able to put a face on the epidemic in the South, and has changed a lot, not only the funding structures of the federal government, but also from private organizations, private companies that are putting funding and foundation dollars toward the South to try to have an impact. So that's impacted the interest. And then certainly the Obama administration has changed HIV and AIDS quite a bit. The prioritization of the administration on domestic HIV and AIDS has been amazing. And as the first African-American president, there has been increased emphasis on HIV impacting the minority communities, and it's allowed us to have additional media attention and maybe even some private and public funding increases in order, because of this this increased attention and focus from the president. And of course, the National HIV and AIDS Strategy, which most people know about now, and this is the first one we've ever had, even though the collective national community was asking for it in the late 1980s, was asking for a national HIV strategy, or an AIDS strategy, and it just didn't happen until this administration. So there's also the Congressional HIV and AIDS Caucus. And the caucus, by the way it's structured, the members have an interest in HIV and AIDS, and how it not only impact their geographical representation, but also their, the representation of the nation as a whole. And we've gotten some great leaders, the co-chairs of the caucus, such as Representative Barbara Lee, great leaders in our movement, and they're people that we rely on a regular basis to help us push our issues forward, and they rely on us as the community members to keep them informed about what's happening and what problems they should be concerned about. So it's important for folks like you, us, all of us, to support these members, especially if they happen to be one of your representatives, and help them do this job, because they can't do it in a silo. You know, the other huge impact that we have are Dear Colleagues letters, and those are basically letters that are created by a member of Congress to get other members of Congress to support an issue. So they're authored by one member, other members sign on, and they collectively are supporting an issue based on whatever the letter is. And this is important because it shows coalition. It shows, you know, a collective response without a lot of effort by some of those members that sign on. They're authorizing their signature to be included, and yet they don't, as an office or their staff, have the additional burden of creating it from scratch. So it's an important tool for us as advocates, and certainly for Congress to be able to know what their colleague is doing. So they don't have to have their staff call each of those offices and say, well, what's your position on this? And do you support this issue? They get these letters, they see the sign-ons, and they add their name to it. So it's a very effective tool, and it's been very effective for example, the domestic portfolio in supporting the NIH funding, the prevention funding through the CDC, and of course the Ryan White funding within HRSA. We also have a HOPWA sign-on letter that's circulating nationally. It currently has 21 signatures in the Senate and 72 in the House, and that's supporting changes to HOPWA and the issues that are related to housing specifically through the HUD program. And then the Minority AIDS Initiative, currently there's 60 sign-ons in the House, but no Republican support. And normally, our organization, our position is that we try to do everything that we can possibly do to be bipartisan. And the way we look at that is the issues don't change, and our needs don't change. The only difference is the people that we're talking to. So our presentation might change on how much we have to explain it, and their interest in the issue, or maybe their party's stance on this particular issue. So our presentation might change, but what we need doesn't change. So we try to keep that as fair as possible. But unfortunately, in something like this, where there's no Republican support, it shows that there is something political going on with that issue. And one of the cases around MAI is that that funding is somewhat considered by some of the members as quasi-block granting, where you're pooling dollars together to accomplish something, which they generally don't support as a party. And so you have to address those issues specifically in order to get their support. So it's an important part of what we do, and an important part of what we ask you to do when members want to hear from their constituents. So strong bipartisan support for medical research, specifically NIH, has been going on for quite a while. And in order to maintain that, as offices turn over, organizations have to keep supporting those positions, keep information coming in, results, and what the impact is on research. And most recently, through the appropriations process and the advocacy we've been doing with appropriations for the federal budget, it came up in a lot of the hearings, complaints about NIH setting aside 10% of their budget for HIV and AIDS research. And so it was other disease groups that were actually advocating or questioning that policy and trying to stop it, basically, so that the money could be distributed in a different fashion. So you constantly are defending things that work right, and you're always looking for opportunities of things that can go wrong. And that's one of the things that's happening right now is there's, in this budget environment, defending what we already have while expanding programs where need is the greatest. So the Ryan White program is a great example of need. It's worked well. It's one of the best examples of a federally funded program that we have in our history. And and it has been historically bipartisan. And just because you don't hear certain members of Congress on the news, and they don't do press conferences, they don't do press releases about their support for Ryan White, they do behind the scenes. And in a lot of cases, that is just as important, if not more important, than the public acknowledgement of it. So we try to let folks know, and certainly when we do advocacy trainings or when we are working with the frontline community, that the misconception that if you're a Democrat, you support HIV and AIDS, if you're a Republican, you're against it, is totally false. It goes back to the members themselves and their interest, their staff's interest, and their own mission. And a lot of times, although somebody may not be focused on HIV or perceived to be focused, it's because they don't know a lot about it. And we've educated a lot of offices that have raised it on their priority list because the more they know, the more they can impact it. And they've taken it on as an issue. So that's very important to note. And that happens all of the time. And it's part of that constant education that we're doing. So the Obama administration priority, which I mentioned already, so the reinstituted office of the Office of National AIDS Policy is a great example. We've got a great relationship with that office. I know Dr. Beal recently met with the director, Douglas Brooks, as well. And it's important for all of us to have these types of connections, even if it's not directly, but through organizations that do have these connections in order to get messaging through, and so that they know what's working and what's not working, or what could potentially not work if they do something. And that's why you always have to watch for what could change or what they're proposing to change. So when you see public comment requested on a policy issue or an administrative change, always get involved as best you can, or get somebody involved to read it, because we have to have your feedback. And for the White House, there is no other disease-specific office. I mean, that says a lot about the level of interest from the White House. And in order to make that successful and keep it going, we have to support that office and keep them informed. And then, of course, HHS, the Office of HIV and AIDS and Infectious Disease Policy, and underscoring the infectious disease piece, which opens it up to hepatitis and other related diseases and strengthens the base of that office. Some could argue that it dilutes the point of HIV and AIDS, but it also means that it's much more sustainable for the long-term future. And led by Dr. Ron Valdiserri, that's really important. And he's been a great collaborator, a great partner, and has been around the federal government for so long that he knows the inner workings. And, for example, he was with the VA for a very long time, and knows all the partners and how things are structured. So supporting offices like his and how he coordinates with HHS and other activities throughout the federal government and bringing groups together. The visible HIV focus at HRSA, CDC, HUD, and the other federal programs is really important. It was required as part of the National AIDS Strategy. Dr. Valdiserri's office was charged with this responsibility, and we try to help support that cross-collaboration. So is there proof of this continued interest in HIV and AIDS? We believe there is. When you look at the strong budget proposals that come out, and even though we have to fight for appropriations every single year, every budget year, and getting a federal budget over the past few years has been very hard. We've been operating under a continuing resolution for multiple years, and until January, and they actually passed a budget that lasts till the end of September of this year. And we don't anticipate that they'll have a full budget before October 1st. So it'll probably be a continuing resolution budget, getting us at least past the elections in November, probably into next year. But what does that impact on our ADAP or our programs? Well, there's been increases. Even with these tight budget situations, that we've been dealing with nationally, and again, competing interests, we've still had increases, smaller increases in other programs. I mean, that's a huge deal. The emergency funding that the President had added to ADAP a couple of years ago is no longer emergency separate pot of money. It's now part of the ADAP base dollars. And again, in this environment, that's a really big win. Of course, the levels aren't where we want them to be, but we don't always get what we want. But maintaining what we have and protecting and getting the federal government to listen to what the issues are moving forward is really important, and that's what I think we're doing a good job of. And when I say we, it's collectively the national community of other national organizations and groups like ours that work together with the folks on the front lines that are dealing with patients every day and sharing that shared voice and opinions. So having a high-level administration focus is really important, and it's shown, again, as proof that the interest in HIV and AIDS in this country is alive and well. The President's involvement in World AIDS Day events, the White House host having the red ribbon on the White House on World AIDS Day. There's always been strong interest by Secretary Sebelius, and as she moves on and we move into a new Secretary of Health, and all indications are pointing to the new Secretary as being a great partner, and certainly understanding, coming from OMB, Office of Management and Budget, having a strong fiscal knowledge of how HIV and AIDS is managed in this country, and through the different departments and the different programs, the way they're administered to the field. And then the administration being concerned with HIV as ACA is implemented, and this is really important because a lot of people, just generally speaking, in decision makers, especially in Congress, thought, okay, we support Affordable Care Act. You're going to have patients moving from Ryan White or whatever their HIV pay source is to this Affordable Care Act program, and you're no longer going to need Ryan White. And when we saw early on that wasn't the case, we're going to continue to need it. And we'll talk about that in a second. But the administration also saw that and put that in the national AIDS strategy, that the two will work together, but it's still going to be badly needed as we move forward with implementation and the issues, and guarding what we have. And a great example of that is CMS earlier this year came out with a proposal to change the 6 protected drug classes and reduce them by 3. And the 3 classes that they were focusing on eliminating as a protected class was primarily mental health drugs. And the other 3 were primarily antiretrovirals that would have been protected. So as an organization, we saw that as a red flag, 1, for the process, but 2, for our patients losing access to medication. So we put a lot of resources behind fighting this change that CMS was proposing, along with other groups. They did as well, and we were successful in changing that proposal and it not happening. And you can't underscore those wins enough, because for us, our vantage point, that was a preventative measure to make sure that those antiretrovirals were not next on the cutting list, because they're an important part of the landscape that we've created, the infrastructure that we have throughout this country, in making sure that patients have access. So moving on to some policy changes and their impact. So the ACA will have a huge impact on care and treatment and prevention. Now, we know firsthand, especially here in Florida and with our patients, that there were a lot of problems, speed bumps, and issues and gaps and things that we've identified and we've heard from our patients and you've experienced firsthand. And those things have to, have a spotlight put on them, and we have to know about them. The feds have to know about them. The program operators have to know about them so that they can fix them. If they really are gaps, if it's an individual issue or if it's a systemic issue, we have to know that too, and in order to make improvements. So we can't patient, well, what are you doing to make sure it doesn't happen to another patient? And that's what our responsibility is. So what are we going to have? We're going to have increased coverage for and opportunities for people with HIV. And regardless of how you feel about the Affordable Care Act or Obamacare or any part of healthcare reform, you have to acknowledge that if successful, this will increase coverage opportunities. And the way that the Affordable Care Act and Ryan White services working together really should improve viral suppression for this country. And I don't think I need to tell anybody on the phone what that means and how we could really impact this disease for future generations if we can achieve that. And we can't do that by retreating and not having enough money. Coverage, of course, depends on the states and how they handle Medicaid and other entitlement programs. And of course, most of you probably know that Florida is not a Medicaid expansion state. And it often gets confused with our state Medicaid program. And we were currently in the process of expanding our managed care portion of Medicaid. But it's not a Medicaid expansion state as part of the Affordable Care Act. And so that has a lot of issues, not only about access. So what do we do with those patients that we could have moved in and other states are moving into the Medicaid program? But down the road, who is going to continue to cover those patients, or how are we going to get access to those patients if we don't expand Medicaid? And since all states don't look the same, how does the federal government respond to those states? Do they treat them differently? Do they treat them all the same when it comes to other entitlements or other programs like Ryan White? So that's an issue we have to watch all of the time and constantly defend, and certainly know the ins and outs of how that impacts our patients. And we get so much of that information from a lot of you and people around the country, and certainly providers telling us how that works and doesn't work. So we also know that Ryan White grantees are going to have to adjust to this new environment. That they've been in a little bit of a bubble for many years on the way things worked, because this was the only place to get support if you had HIV. You had to go to Ryan White if you wanted treatment, and you had CDC prevention programs for prevention, and there was a little bit of a firewall in between those two, and the two don't cross over. Well, that's all changed with the National AIDS Strategy, and those programs not only have to cross over, they should cross over, and there should be linkage to care and prevention for positives and other opportunities to reduce infections in this country, along with adequate treatment. And a huge question is whether organizations are going to be able to survive this change in environment, and the discussions about merging or collaborating with organizations that provide direct medical care. Because if you remember the history of this disease, not a lot of organizations were founded on direct medical care. It was all around supportive services, access to services, directing people through case management or medical case management, and to get them into care. It wasn't about the care itself. So what's the future of those organizations if they're not directly related, or they're not billing through the marketplace plans, or if they're not part of this new system? What happens? And that needs to be discussed. And organizations around the country, and a lot of you are having those discussions with your boards, and there's some hard decisions that have to be made, but it's a reality. And certainly the level of care for patients will change too, and maybe even access to those patients. We've been fighting for broad access to providers through these marketplace plans. So if somebody signs up, they don't have to lose their doctor, they don't have to lose their pharmacy. And that's a fight we're continuing and will continue even past the enrollment that begins in November. So there's lots of gaps in the way those plans were rolled out and the way that they're changing, and we have to make sure that our patients are protected. And specialized HIV care, and will it be available to our patients? Are the centers that are actually on the approved list plan or an insurance plan, are they able to treat the person that needs the care? And those are things that have to be addressed. So moving on to the future of Ryan White, which is the core of our care and treatment for HIV in this country. So the program itself, through the legislative process, expired in last September 2013. But it didn't sunset, which means that the law still exists, but it's not reauthorized. So it can still be appropriated to. And I think the collective community, although we don't have consensus around, the experts around this issue, but it's fairly safe to say that collectively we all agree that Ryan White, the program, should be reauthorized at some point in the future. But now we get into the what's and the hows of that happening. But while we discuss that, we still have to deal with the annual appropriations process and the changes to this program. So this is what's happening. We need to analyze the impact of the Affordable Care Act through studies and data. And there's some studies that will be coming out in June and July, and there will be some that are ongoing. Beyond that, showing the overlap between the programs, how many people got enrolled, how successful were they in transitioning from, being fully dependent on Ryan White to other pay sources. Was the patient able to not have any outside support once they were, rolled into a new, let's say, marketplace plan or other pay option, and what were those changes? The need to continue and provide coverage completion to the 72% of the clients who already have some type of a coverage. And coverage completion, if you haven't heard the term, you'll hear more of. You've also probably heard it as wraparound. So Ryan White can pay for out-of-pocket expenses and premiums, co-pays, so that the person that receiving the services can actually maintain that insurance coverage, which in most cases is much more cost-effective than having them fully supportive on Ryan White. And there's a lot of debate about where do you draw the line? When do you support somebody? When is it cost-effective? When is it not? What measurements are you using to determine that? And states like Florida have had to battle this discussion and have asked themselves some hard questions in order to create policies and programs that are going to be effective to the community and not cause a barrier to the patient or to the case managers or any of the providers that are trying to get them access. So the process, creating the process itself is very complex, and for any of you that are involved in it, it doesn't matter what solution you provide and that sounds logical, there will be a scenario somewhere, because our counties aren't equal. There will be a scenario somewhere where it'll cause a problem, no matter which way we go. We also need to determine the level and the cost of those coverage completion services. So do we have caps on how much we help? Does Ryan White, stop at whatever, 900% or $900? I'm sorry, per person. Do they put those types of caps on them? So all that has to be determined. And some plan benefits are better than others. Some supportive services can also help achieve viral suppression. So it's an important debate, and it's an important part of the support for the patient in order to keep them healthy. And then the need to account for people that are not covered by ACA. So there are lots of people that don't qualify for these plans, don't qualify for any of the supportive services, and what happens to those folks? So there has to be a safety net. Ryan White was created as the safety net, and we need to continue to support it as being that. And then how to address non-medical expansion states, or non-Medicaid expansion states, rather, like Florida, because there's a debate right now that for states that did everything they could to change their system of health care, expanded Medicaid, provided state exchanges, marketplace plans, and had a variety of issues, to help people transition from another program like Ryan White into these. So they did everything right, and what should their contribution, or how much of the Ryan White federal resources should they get? And so some people see that as, if Florida, for example, who didn't expand Medicaid, and a lot of perceptions didn't do it right, should they technically be rewarded with additional Ryan White funding to fill that gap? And so that debate is going on. Our organization's position is, it's not about Medicaid versus Ryan White, it's about the patient. So if Florida doesn't have the coverage, then Ryan White's needed to fill that, to ensure that the patient doesn't fall out of care. But that's something that everyone, including all of you, have to decide your position on that, and how you can effectively communicate that to your representatives. So again, on the future of Ryan White, we're needing to advocate for continued funding. We ask all of you all the time, and of course every time we fight for appropriations, to help us with that. And then, the reauthorization of Ryan White is going to be difficult. We know changes are going to have to be made. Community consensus is going to have to, in some form, happen, so that we don't have mixed messages going to Congress. We have to have support of the administration, and then congressional support, not only from the members, but from the staff that have to make this happen. And we can't underscore that enough, that how important staff is to this fight, congressional staff. And then the partisan politics, the public things that stop us and cause gridlock or cause barriers that have nothing to do with our disease or our advocacy of what we're doing, but it does impact us, and we have to know what those are. And we have to continue to fight for funding for all of the categories, not just Ryan White, but for NIH and CDC, and that has to happen on an ongoing basis. So, quickly moving on to the future of HIV prevention, the Affordable Care Act covers preventative services, HIV testing, and as well as behavioral counseling to reduce STDs and others. And so we have a lot of opportunities here to really impact this disease, and grantees have to learn how to bill for these services. This is brand new, and we've been saying it for a few years. That providers need to change the way they do business. So if you only received Ryan White, or you only received CDC funding, and that's all you did as your organization, you're going to have to change the way you do that. You're going to have to start billing insurance companies for HIV testing. You're going to have to know how to do it and be able to do it, or you're not going to get any support. And that's a real possibility, and those things are rolling out as we speak. Some of these programs, and the states are trying to tackle that and how they roll this out. And at the same time, we need to advocate for continued funding for HIV testing and all the associated services, because right now, HIV testing, for lack of a better description, is on the chopping block, because if you can get reimbursed by an insurance company or through a marketplace plan or something else, another source, then you don't need it. The CDC shouldn't be paying for those tests. But we've got to get the organizations prepared to do that. And we can expand to other preventative services in the future, that impact us. Moving on to HOPWA, the administration has offered a modernization bill of the housing program. I'm not going to go through all of these because you're going to be provided with the slides, but basically the heart of it is a new formula for determining how it's funded. So 75% of the dollars are going to be based on AIDS cases, from cumulative AIDS cases to HIV cases. So that's 75% of it, and then 12.5% is poverty index, and 12.5% is cost of housing. So that's the 100% funding, with phased in over 3 years with a hold harmless, so that programs and areas don't see a loss greater than 10%. And there's mixed community support on this, because obviously if you're going to lose money for your program or your area, then you're not going to, that's going to impact your decision. So we also have, the policy changes. So retirements, you hear about it on the news, but for our community, that's huge. So, between these folks, Waxman, Harkin, Coburn, Christensen, and others, that have been leaders in the HIV community, we're losing these folks that have long-term institutional knowledge about the disease and how the federal government can impact it. So we have to start over educate those staff members to get them up to speed, because if they're not up to speed, their members not going to be up to speed. And and new representatives and senators coming. We've got an election coming this fall. And a lot of these folks, especially the staffers, weren't around in the 80s and 90s. Some of them weren't even born. And they're not even familiar with the Ryan White program, let alone the fact that Ryan White was a person, and the issues related to Ryan and Jeannie and what they went through. So we've got the midterm elections coming up. That's going to have a huge impact on us. There's a possibility that the Republicans can gain majority control in the Senate. And if not, they're certainly expected to increase the number of seats. But if it occurs, that means there could be new committee chairs. There's increased oversight and changes to the Affordable Care Act. And I don't think anybody would dispute the fact that there would be a continual or increased attack, for lack of a better description, on the Affordable Care Act if that happens. And modifications to entitlement programs will be under fire. It will be one of the targets, and something that we're going to have to defend against on a regular basis. And it's likely that the Republicans are going to maintain the House. And again, these are estimates, so things can change, and so it needs to be watched closely, and people need to vote. You can't assume that if the news polls say that so-and-so is ahead, or by so many points, that you don't have to go and vote, because that's not necessary. So as an organization, we always encourage everyone to exercise their right to vote. And certainly if the ranking member of the Energy and Commerce Committee changes, depending on who that is, that's who authorizes the Ryan White program. So that could have a huge impact on how we move forward. Just like the 2016 presidential election, so far away, but when you are in Washington, D.C., you meet with these offices, policies and decisions they make today in many cases impact the presidential election or issues related to the election. So they don't want to set a precedent for something that may impact the election or a campaign. So it is impacting us right now, but it will really impact us once the campaigns start ramping up. And then, keeping the domestic HIV has been a priority for the president, but we need to keep it that way. And will that continue with the next administration, no matter who it is, and what party that is, or what person that's going to end up being? They have to be supportive of us, and we have to try to make them supportive of our community. And the community itself, including all of you, must advocate for candidates in both parties to make HIV a priority. And this isn't lobbying. This is just saying to your representative that comes knocking on your door, or comes to do a session in your community, that you want HIV on their platform as part of their discussions. And then the 2016 House and Senate elections as well. And then when do we reauthorize? Do we wait? Do we try to do it before this president leaves? Or do we try to wait until the new leadership is in? So that's a debate as well. So to try to keep us on time, I'm just going to roll right into the state of Florida updates, and then we'll move into some questions. So just some quick things. Although generally we were successful in this legislative session, the bottom line is we ran out of time. There were less days available than prior sessions, and we just didn't have enough time to get everything completed. So the session ended on May 2nd without any future reconvening date established. So that means that pretty much the bills that we were hoping were going to pass that didn't pass, we're just going to have to start over next year. So the passage of this record $77.1 billion budget, so $3 billion larger than last year's, but there was a $1.2 billion surplus that they were able to achieve, and they used that. The governor and legislature met their goal of providing $500 million in tax and free cuts, and obviously it's not rocket science that some of that was politically motivated, because this is an election year. The Health and Human Services portion, which most of us are interested in, totaled $31.9 billion, which is quite a bit. And our successes were few. I mean, bills that had passed. Certainly the THC medical marijuana bill passed, and as much controversy as there is around that, that is something that we have to deal with. The other items that were passed, the rollback of the motor vehicle, so other things other than what directly impacts us as a community on a day-to-day basis. They didn't get, in our opinion, a lot accomplished, again, because they ran out of time. The legislation that failed, specifically Medicaid expansion, the attempt to do that again, a bill to allow advanced registered nurse practitioners to prescribe, that didn't succeed, and other bills that they tried to put through the session that, for a number of reasons, didn't succeed. But the ones that we specifically worked on, so the hepatitis C testing, we got a lot of praise for the work that was accomplished, and through the summer, we're going to be working on an education campaign for legislators to learn more about hepatitis C, because in some cases, when we went and visited their offices, that was the first time they were hearing about it. They didn't know anything about it. They couldn't have told you the difference between hepatitis A, B, or C. They couldn't tell you how it was transmitted or what it means to your body. So we have a lot of work to do, and this was anticipated, but it did not pass, and we're going to work on that again for next year. We were surprised about the HIV testing bill, changing it from an opt-in to an opt-out, and this is strictly a victim of running out of time. And the fact that that bill had passed the House unanimously, 114 to 0, says a lot about our current legislative member structure and what they were. But again, it died in Senate Health Policy, and we just ran out of time to get it passed. The Infectious Disease Elimination Act, which was the syringe exchange pilot program, it was successful last year as it's starting off. This year it gained even more momentum, got a lot of support. It just ran out of time again, and wasn't able to be passed before the calendar ended. And then the Patient Access and Continuity of Care. This was an important bill that was really impacting providers and trying to reduce barriers to getting access to medications, changing step therapy. And this is something that we're going to continue to work on and move forward with, but there was a lot of complications around this, and it died in committees, so we'll be working on this summer on strategies around getting that going again. And then the Medicaid extension bills, which are similar to the expansion to try to use federal dollars to fill gaps for services for patients that are falling between the cracks. The Florida Kid Care, thought that was going to pass, didn't, which was expanding access to health care through the Florida Kid Care existing program, and that died in appropriations, and we're not sure of the status of that for next year, but chances are that's going to be repackaged or represented. And then the state of Florida budget. So the Final Appropriations Act included no increases for ADAP. So we have general revenue. For those of you that don't know, we have general revenue that goes to the federal ADAP program and the AICP program that we get federal dollars for. But we also add our own state dollars to that. And this state has been, this is another bipartisan issue that we've been very successful in Florida about getting those dollars and keeping them there. But it did include an additional almost $14 million in federal budget spending authority, and that created some ruckus in the community because people saw that number and thought that was new dollars. And it's just spending authority in anticipation of a federal reward, so that when the dollars come from the federal government, the programs are able to spend it. And we fought hard for an additional $1.7 million to get the hepatitis program back up to its earlier funding levels through the general revenue. It wasn't successful, but a $200,000 increase was successful. Huge difference between $1.7 million and $200,000. But we're currently working with the state now on how that's going to be put out, and how the health departments are going to be able to increase access to testing and care and treatment with this minimal amount of money, and try to have as big as impact as possible. And the request for funding process will be developed hopefully very soon. And then these changes, something that continues to be an issue, the rule change for Rule 64D, which is eligibility requirements for HIV patient care programs. That final rule has not been released yet, and when it does, we're going to let everybody know so that you can comment on it. And it's something we've been following for several months now. And the Affordable Care Act in Ryan White in Florida. So the marketplace begins enrollment again in November 15th. A lot of people forgot that it was originally October 1st, but it was moved back to past the elections to November 15th. And currently the Florida ADAPT program is developing a system and mechanism to provide those wraparound coverages, and so that we'll be ready for people who enroll next year and are in the marketplace plans and be able to get that coverage completion. And then around gaps, we talked about gaps in services for the marketplace and problems it's caused for our patients. And this is an opportunity, and you'll get this survey directly, but this is an opportunity for you to provide some feedback to us so that we can get this to the proper decision makers. And so this survey will be coming out to anybody who's registered, and you'll see it through multiple communications. So you don't have to write this down while you're watching this. And then, as I mentioned, the Florida Medicaid Managed Care, this is the rollout schedule. We wanted you to have this in their website so that you could monitor it and how it impacts your region if you're one of the regions that's in this rollout schedule, and how that'll happen in your area. And then finally, the Florida DOH, Department of Health changes. The hepatitis program is moving to the STD section. There's been significant staff turnover, and we're hearing every day of more turnover. And we're waiting to hear about the new HIV and AIDS administrator that will be announced hopefully very soon. So thank you. Dr. Beal?
Great job, Michael. Thank you so much. And we have a speaker question for you. A speaker or a participant has asked, do you see any advocacy role for organizations such as the League of Women Voters and now in Florida, CHAIN, if I can see that correctly?
And Florida Chain?
Yes.
Absolutely. And this is the perfect environment for us to coexist with these other organizations and try to work in the same direction. So collaboration is key, and we would love to on our